Welcome back to QD Clinic. We've been away for a while. QD Clinic is brought to you by RheumNow.live 2025, February 8th and 9th. Great faculty, shorter lectures, more discussion. This is where knowledge meets practice. We hope to see you there. Today's case begs the question, is it CREST or is it diffuse disease? A 49-year-old white male presents with tightness and joint pain, tightness in his fingers, and at the outset, in early 2022, he had some shortness of breath. Came in to see me. He had significant rainouts. He had tightness in his fingers, back of his hand, distal forearm, but nowhere else. Not on his face, not on his abdomen, not on his chest, not on his legs or his feet. ANA was done and was positive 1 to 25/60 in a nuclear pattern. Other autoantibodies were done and were negative for centromere pattern or SCL70, RMP, SM, or double-stranded DNA. Because of the edema and the tightness in his fingers, I gave him a taper of prednisone from 30 down to 5 milligrams over 3 weeks. He noted less swelling and puffiness. He noted improvement in the joint pain he was having in his hands and his elbows. When he returned in 3 weeks, I put him on methotrexate, folate, aspirin, amlodipine, and lovastatin. Why the aspirin, amlodipine, and lovastatin? He does not have hypertension. He does not have hyperlipidemia. I view systemic sclerosis in a limited or diffuse form to be a microvascular disease. This is my regimen of microvascular prophylaxis with aspirin, low-dose amlodipine, or vasodilator, and lovastatin. I've been following this man for over 6 months. He's done fair. His skin tightness has not progressed. In fact, when you look at his modified Rodnan and Skid score, it was initially 14, and then in the subsequent visits, it was 14, 16, 12. Last visit, a month ago, it was 14. He still has sclerodactyly. He has it tight skin up to the distal forearm. He did have a digital pit scar, but that resolved, and it's been pretty minor. Rainouts has become less of a problem with his vasodilator therapy. He does not have telangiectasias. He does not have calcinosis. He does not have esophageal dysmotility, and he does not have any further shortness of breath or organ involvement. He denies dysphagia. So Raynaud's is a minor problem. His pain last visit was mainly in his elbow and a few fingers. Morning stiffness of 30 minutes. He does not smoke tobacco. Occasionally drinks coffee, sometimes 6 coffees a day. He's unable to work because of this condition he has. And what did I call it? Initially, I called it CREST syndrome. But then the more I see him, the more I wonder. He's got a digital pitting scar. He's got above the hand, but CREST, you can go all the way up to the elbow and still qualify as limited systemic sclerosis. He does not have a centromeric antibody, but he has a nuclear antibody, but then again, he doesn't have an SCL70 either. So I'm concerned about risk, but what would you call him? Again, his skin did progress above the wrist. He did start out with shortness of breath, and he has a nuclear pattern ANA. But he has no evidence of GI, renal, or lung disease. He does not have calcinosis, esophageal dysmotility, or telangiectasias. What do you call it? I'm calling it CREST syndrome, limited systemic sclerosis, and I'm treating that as I do with methotrexate and my regimen that goes for microvascular therapy. But what would it take for you to be more aggressive? If you were doing CAR T-cell therapy in your clinic, would you give this to this man? I don't know. I might want to. But really, I have to say he has limited disease at this point. I'm calling this CREST. What would you call it? Come to RheumNow.live and let me know what you would do.